Hello, my name is Dr. Meghan Davis. I'm the director of the Johns Hopkins Post Center, and I'm here to talk about the role of occupational health and industrial hygiene in total worker health. When we consider integrated approaches to total worker health, we think about a goal of health and well-being, and this may be operationalized through many different activities. Some of these activities focus on managing worker illness or promoting health. What I'd like to talk about today is how the activities to prevent harm are essential to promote health and well-being. This can include occupational health psychology as well as occupational safety and health approaches. In this, let's start with a primer on occupational health. There are a number of different occupational safety and health agencies. In the United States, we primarily focus on OSHA and NIOSH. OSHA is the Occupational Safety and Health Administration, and OSHA is responsible for workplace safety and health standards. These are often rules and they can be enforceable. Whereas NIOSH, the National Institute of Occupational Safety and Health, primarily focuses on the study of worker health and safety to help promote the development of guidelines and other recommendations. Two other key agencies include the Mine Safety and Health Administration and the Bureau of Labor Statistics. At the global level, the World Health Organization includes activities focused on occupational health. The International Labor Organization works extensively within workplace safety and health. There are also regional and country-specific agencies, including the European Agency for Safety and Health at Work and individual country agencies. Work-related diseases are really important to the global burden of disease. These represent illness or injury in which the work environment plays a role in the etiology or causal relationship. The World Health Organization estimates that almost 2 million people die annually from work-related exposures. When we consider in the United States how this has shifted over time, and in particular, how it has shifted with the recent COVID-19 pandemic, you can see that on the left, we have the total reported injury and illness cases from 2019 to 2022, which identifies that most of the reported cases, regardless of year, come from injuries rather than illnesses. However, within illnesses, if we look at the chart on the right, we see the case counts of illnesses and broken out by all illnesses and respiratory illnesses for the same time period. So if we look at the pre-pandemic period, you can see that respiratory illnesses made up a minority of illnesses that were identified in the occupational health sector. But during the pandemic, this rose dramatically. There are a number of foundational concepts in occupational health that I'd like to review. One thing we understand is that occupational exposures to hazardous agents, this could be chemicals, this could even be biologic agents, depending on the workplace, may be higher than general or community-based exposures. This is particularly true when you have these particular hazardous agents either used or through activities conducted at work, greater exposures within the work environment. There's also a form of selection bias that we recognize in occupational health that tempers this higher exposure. So on the one hand, you may be more highly exposed at work. For example, if you work with certain chemicals, then you may be more highly exposed than someone in the community. But at the same time, the healthy worker effect indicates that worker populations tend to experience lower rates of adverse health outcomes compared to that general population because they have to be healthy enough to work. So they come into work generally more healthy than the general population. So our workforce typically does not include infants or children or elderly people who no longer are able to work. And therefore, the healthy worker effect shows that when you do a research study or you're doing surveillance, that it may be harder to tell when there are increased health outcomes. In addition, workers who experience more severe effects might be selected out of a group. So if you're looking at a population in a cross-sectional way, you're just coming at one point in time and you're doing a survey, anyone who previously has had a problem with the exposures at work and no longer is at that workplace may not be part of the group that you are able to evaluate. I've heard anecdotally when I work in agricultural settings that there are workers who start working in agriculture and can't stay more than a few weeks because they have really severe reactions to working in an agricultural setting, whether it's related to the higher levels of endotoxin or allergens or other kinds of exposures that might be on a farm. And so this is an example of the potential for selection out of a group. Finally, with occupational health, we have to consider the window of exposure. So the duration tends to be limited by how long you're at the job. This might typically be an 8-hour day or less. And so even though the exposures may be higher, they may be more limited. So someone who is in a home environment might experience exposure durations that are much longer than 8 hours a day. There are a number of different kinds of harmful agents. We might consider these the different types of exposures. Certainly, physical exposures, such as noise or radiation, can have serious consequences, as can chemical exposures, for example, pesticides or volatile organic compounds. We're all a little more sensitized now to the importance of biological exposures. So, microbes, such as pathogens, including viruses like SARS-CoV-2, but also other biological agents such as allergens or endotoxin. We also think about exposures as including ergonomic, safety, social, and psychological components, and these can be particularly important for total worker health approaches. If we consider work-related exposures within the toxicological paradigm, then we would think about the framework by which the exposure may be related to health effects. With the toxicological paradigm, we recognize that you have exposure that's outside the worker at the work site. This then will be internalized, and it depends on the agent as to exactly how this happens. And you might be able to measure an internal dose. The biologically effective dose is the dose of the agent at the actual site in terms of the cellular level where that agent will have an impact. And that will result usually at the cellular level in early biological effects that ultimately can influence altered structure and function within organ systems or the body that manifest as health effects. Where we measure our exposures can be anywhere along this paradigm. But we also have to consider how there may be effect modifiers or different susceptibility factors that will influence the way this framework plays out in an individual worker. And so considering vulnerable worker populations is particularly important. Some of these may be biological susceptibility to work-related exposures. You might consider age, gender, pregnancy status. An example of the latter is there are certain stages of pregnancy where the fetus may be more susceptible to certain exposures and the outcomes associated with them. We also might consider comorbidities as important biologically to susceptibility because they can influence the manifestation of disease, or they can influence the way the body is able to respond to the agent. There are other ways in which worker populations can be vulnerable. And in this, we think more about precarious workforces, where there may be something related to power dynamics or discrimination that makes them vulnerable in other ways. So if we think about age and gender in this context, we might think about child labor or older workers as being more marginalized. We might think about economic, social, or political marginalization, which can include migrant workers and workers living with disability. Finally, the informal economy can be important because of the lack of representation of this workforce in terms of the agencies and other groups that are designed to try to promote worker health and prevent harm. When we think about the toxicological paradigm and how exposure can be related to health effects, we could place the toxicological paradigm on the right-hand side of this figure, where exposure modified by susceptibility factors can result in health effects. But when we think about what to do about these exposures, you need to consider upstream the source of the agents themselves and the routes of exposure, whether these are through inhalation, ingestion, dermal exposure, or injection. And then we think about ways to either eliminate the source, so that might be through various control measures or substitution of agents, or we might think about ways to limit the exposure at the worker level, such as use of PPE. And all of this collectively might encompass risk assessment and management activities. NIOSH has developed a model called the hierarchy of controls that suggests that physically removing the hazard, otherwise known as elimination, is considered to be more effective to protect workers than using things that are at the worker level and might rely on individual behaviors. And so that's shown with the color ramp from most effective at the top to least effective at the bottom. Elimination, physically removing the hazard as the most effective, might not be possible. And so substitution, replacing the agent with something considered to be less toxic, might be an alternative. Using engineering controls to isolate people from the hazard is also important and may be done at the industrial level. I certainly use engineering controls in my own laboratory when I'm working with infectious agents, where we have biological safety cabinets that help to make sure that my breathing zone doesn't contain any of the air that is inside the hood where I'm working. We also might consider administrative controls, changing the way people work. And so this might mean doing things in certain areas or at certain times of the day to reduce the potential for exposure. An example of administrative controls could be to reduce heat-related exposures among farm workers, to have the work conducted early in the morning before it gets too hot. Finally, use of personal protective equipment or other behaviors that may be health protective, such as hand washing, would fall at the bottom as least effective, but certainly part of our suite of potential interventions that might be employed. When considering how to reduce exposures, a lot of larger workplaces will conduct workplace monitoring, often through industrial hygienists or other occupational health and safety specialists. With exposure monitoring, this could be ambient or personal. Ambient would be in a room or related to the activities that are being done. Personal might be equipment that's actually placed on the worker in order to measure their exposures at a health relevant location. There are a number of occupational exposure limits. So if you're measuring these exposures in the workplace, these might need to be considered in order to identify if the exposure concentrations are in an area of concern or if they are within the either standard or recommendation for the limits that we might expect. So these include PELs, RELs, TLVs, and wheels. PELs are permissible exposure limits. This is an OSHA standard for allowable exposure over an 8-hour period. That 8-hour period representing typically a time-weighted average, or TWA. On the other hand, a recommended exposure limit, or REL, is a NIOSH recommendation for occupational exposure limits. So it's less enforceable, but still quite useful in terms of estimating whether the exposures measured could be of concern. In addition, there are guidelines for airborne concentrations of substances that have been promulgated by the American Conference of Governmental and Industrial Hygienists called threshold limit values. If the concentration is below the TLV, then the expectation is that most workers should be unaffected from a health effects standpoint. Finally, the American Industrial Hygiene Association has additional guidances on exposures called workplace environmental exposure levels. It's important to consider these when measuring exposures in the workplace. In addition to direct environmental monitoring, there are techniques for exposure assessment that include questionnaires, self-report, expert judgment, using job exposure matrices or GEMs, and taking an occupational history. Other kinds of workplace monitoring include biological monitoring. These are often samples from individual workers, samples that include blood, urine, saliva, depends on what's being measured as to what the most appropriate biospecimen would be. These are beneficial in that they integrate across different routes of exposure. So for example, if an agent might have both dermal and inhalation exposure, but you're only measuring the agent in the air, you might miss the dermal route of exposure. But biological monitoring should capture that. It also integrates the benefits of mitigation strategies. So if we have exposure to something that's airborne, but people are wearing masks and potentially masks that are appropriate for whatever that exposure is, then the mitigation strategy of using the mask should be built into what we expect to see from the biological monitoring. Finally, we have health effects monitoring or clinical surveillance. This is where we look at clinical outcomes. The challenge with clinical surveillance is that there are few conditions that are truly specific to a particular exposure or work site. What we recognize is that there are many things that can cause clinical illness. For example, kidney disease. And because of that, we might not be able to take that monitoring and say, okay, we've got some increases in people with kidney disease and tie it directly to an exposure that is specific within the workplace. So if we think about this as a continuum, we have our toxicological paradigm, right? We've got the exposure, internal dose, all the way to health effects. We might, for ambient monitoring, consider the exposure and the various media that we may use for that measurement. We may sample air, potentially soil, water, or food, depending on the work site. With biological monitoring, we think about biomarkers of internal dose, of the biochemical effects, and of the biological effects. And so biomarkers for internal dose include the agents themselves or their metabolites. The biomarkers of the effects at an early stage could include DNA adducts or protein adducts. And biomarkers of biological effects could include immune effects, genetic changes, or enzyme changes. And then the health effects would be measured through clinical surveillance. Certainly, clinical surveillance shows sort of the maximum significance for health because you're seeing the health effects. And so we might think of this as being a continuum from ambient monitoring to clinical surveillance in terms of the significance of the findings for health effects.